The interesting fact is that PCOS is the most common endocrine condition affecting women of reproductive health. We know about overweight obesity is about 50% of women with PCOS. There's a high degree of conversion to type 2 diabetes later on in life. There's a higher risk of having endometrial hyperplasia, which is thickening in the lining of the womb that is a precursor to cancer. And that's because women with PCOS don't ovulate, and therefore the lining is thickened, and then it can become cancerous basically with time. There's higher prevalence of sleep apnea, where there's snoring and low oxygen at sleeping time, and that can increase the risk of stroke and cardiovascular disease. There is very, very prevalent and often not addressed depression, anxiety, body image issues, and
disordered eating.
Correct, and psychosexual as well. There's dysfunction. There's a lot of that among couples that we see with PCOS coming to have fertility treatment, basically. So really, the key, if I am to say something today, is we need to do a better job to look at women with PCOS holistically, understand all their symptoms, and help them to get better across all the different systems that are affected by this syndrome.
Welcome back to the Women's Handbook podcast, How to Be a Woman, where we discuss everything women's health from menarche to matriarchy. I'm Dr. Natalie Hutchins, and today we're talking about polycystic ovarian syndrome, or PCOS for short. Now, whilst PCOS is one of the most common diagnoses in women's health, it is also one of the most misunderstood. From the name that really doesn't reflect the complexity of the disease, to the fact that it's not just one disease and that it can show up for different women in different ways, to the pill and whether it really is a treatment or whether it's just a way of dismissing women, there is just so much that we need to talk about to help women with PCOS understand their bodies, get the right help, and advocate for themselves. So today I'm joined by Dr. Basil Watter. He's an associate professor in reproductive medicine. He's a researcher and he's an expert in PCOS. We're going to talk about it all: how to get diagnosed, how the diagnosis differs in teenagers, what options exist for women who don't want to take the pill, and we're going to talk about the pill itself and what it does well, what its limits are, and try and tackle some of the misinformation in this space as well. So let's get started. Hi, Basil. How are you?
Hello, Natalie. Very well. Yourself?
Very well, thank you. Thank you very much for joining me. I'm really pleased that we're doing this. I think, as I said in the introduction, I think that a lot of women have heard of PCOS, but unless they have it themselves and have kind of done a deep dive into it, it's often very misunderstood. And I think one of the main reasons for that is the name. You know, it really doesn't represent what PCOS actually is. So tell us, how do you describe PCOS to your patients?
A fantastic way to start this podcast today. And I think historically, we had a hard time to actually come up with a unified criteria to diagnose PCOS. And this all changed really about 25 years ago or something when the Rotterdam criteria came up. So imagine, before that, we didn't even have a proper way to diagnose women with PCOS in terms of coming up with a syndrome that manifests about all the different symptoms that comes under that. So that led to a lot of confusion. Then it was some time before we came into adopting this Rotterdam criteria. And then with time, it got refined. Now, the interesting fact is that PCOS is the most common endocrine condition affecting women of reproductive health. Wow. So it is very, very prevalent condition. In the UK, it's about 10 to 15% of women, which is a huge population. And the common barrier is that the presentation really varies from one person to another.
Yes.
So, and there are some of us would experience different phenotypes. So there are 4 described phenotypes in PCOS, which basically is a collection of the different symptoms that come up. Mm-hmm. And to be diagnosed with PCOS currently, as per the Rotterdam criteria, you need 2 out of 3 symptoms. So number 1, irregular or absent period. Yeah. Number 2 is either visible hyperhirsutism or acne, or what we call hyperandrogenism, where basically the androgen levels, which are the somewhat male hormones, are slightly increased. Obviously, a woman's body has male hormones, but in much, much lower levels compared to a man. Yeah. Or sometimes they aren't hirsutism, but the levels in the blood of testosterone are increased. So that's number 2. And then number 3 is an appearance of multiple cysts on the ovaries on the ultrasound, what we call PCOM, polycystic ovarian morphology. Now, we call them cysts. They're actually not cysts.
I was just about to say that, yes.
They're actually follicles that have arrested in their development, in their pursuit to become mature eggs. They stopped because of the hormonal imbalance.
Right.
So any collection of these two together, you can make up 4 different phenotypes and how it can present.
So when you talk about phenotypes, that's you talking about the fact that PCOS isn't just one disease, and actually it shows up for different women in different ways.
Correct.
So let's talk about those subtypes then. How? Because I think, again, one of the misunderstanding of PCOS is that it looks the same in all women. So it's a woman with overweight or obesity who has hirsutism, who has irregular periods, and that's just it. And if you're anything outside of that, you can't possibly have PCOS, but that's not the case, is it?
100%. So this is one of the most prevalent phenotypes. This is one of the commonest. But obviously, a small population or small subgroup of these women will present as lean. They are not overweight, but they have very potent hirsutism. So they have excessive hair, they have a lot of acne. And this subgroup tend to have worse sort of long-term health outcomes.
Right.
And some others will present with just a minor hirsutism, with just the appearance of the ovaries on the scan. And some will basically present with just the irregular periods with a little bit of hirsutism. So they can vary quite a lot about what symptoms manifest so that can get diagnosed. Now, that leads into the next step, which is, when does actually a woman go to seek medical attention to get diagnosed with PCOS? And if you look in clinical practice, there are commonly 2 sort of main points. Number one, when she's finishing her menarche or teenage years. And by the way, the criteria we discussed does not apply to teenagers. So only applies for an adult. And that is because it takes about 8 years for the hormones from menarche to stabilize. So having irregular periods and hirsutism or some acne in teenage years is very normal.
Got it.
And a lot of women get over-labeled or over-diagnosed with PCOS, but we don't have a criteria in teenage. We can discuss that slightly separately.
Yes.
So the number one point of reaching diagnosis, a lady going to a GP or to say, look, my periods are irregular, I'm slightly putting on weight, I'm having this excessive hair, is that first few years, 18, 19, 20. The second point, which is one of the commonest, is we're actually trying to get pregnant. They don't know they have PCOS at all.
Yeah.
They just met a partner, they're starting to try, but they're failing to get pregnant spontaneously, and then they go to a fertility clinic and they get told, well, actually you have PCOS, but they never knew about it.
Yes.
So these are the 2 commonest sort of points, and that has to do with A, lack of awareness about how the symptoms are manifesting, and B, I think, which is something very common, also health professionals don't know a lot about PCOS.
Yes.
And this is something we're working very hard to sort of promote in the UK. We have a specialist course for GPs. So we want GPs to know more about PCOS and how to initially manage it, when to refer, when to not refer, to help patients get that timely diagnosis, basically.
Absolutely. I mean, if we've got a condition that affects 10% of women, it is absolutely something that needs to be the bread and butter of GPs, doesn't it? Absolutely. Indeed. Okay, so let's just go back to talking about the phenotypes then. So phenotypes essentially just means a different subtype that presents in a different way for different women. Is it that those subtypes have a different cause? So is it that the mechanisms of those driving those phenotypes are different for different women?
The honest answer is we don't know how they manifest. So if you go to a medical convention of endocrinologists and gynecologists in one room, the endocrinologist will tell you PCOS starts in the brain and the hypothalamus because of irregularities in the hormones. And the gynecologist will tell you, no, it starts in the ovary because of the increased thickness of the ovarian stroma, the increased production of like testosterone and other androgens. And then that leads to insulin resistance, and that creates that vicious cycle of weight gain, irregular periods, and so on and so forth. We don't have a clear understanding of the mechanisms of how these work out. There are currently some studies, notably the DAISY study run by Imperial, which will give us a lot of understanding because they're looking into the epigenetics of PCOS and how it manifests into different phenotypes based on the epigenetics of every woman. So there is this hypothesis that depends on how your receptors respond to your hormones, this is how your phenotypes manifest. We're not certain yet. I think there's more and more investment in research to really understand that, which is very positive, because we hopefully will be able to diagnose it a little bit sooner and refine the treatment to each phenotype, because each phenotype will need slightly different individualized treatment plans. It's not like off-the-shelf treatment that you give to every woman with PCOS.
Absolutely. And one of the things I think I've seen from some women is that with the advent of at-home testing, you can very easily test your hormones at home, and that's happening quite a lot. And a lot of women are saying, well, actually, I've tested my hormones and they give me a picture of biochemically having PCOS, but I don't actually have any of the other symptoms. I'm not particularly hirsute. My periods are okay. Mm-hmm. What's going on there? Is it that PCOS exists on a bit of a spectrum? So yes, you talked about the Rotterdam criteria and those 3 elements of diagnosis, but what if you don't neatly fit into any of those?
Yeah, so it is a spectrum, as you highlighted, and it's also a diagnosis after having excluding other potential causes. So for example, a lot of women will have pure hypothalamic irregularities, or what we call hypothalamic amenorrhea. And there is a slight sort of conjunction in that Venn diagram, and a small portion will have both. Some women, for example, have adrenal hyperplasia. They're a small minority. So I'm a bit wary of that at-home testing because it often causes more anxiety than resolution. I'm all for patient empowerment and patient education, and I think this is good that we're helping the patients to understand and know more about their bodies and their physiology and pathophysiology. Mm-hmm. The problem with this at-home testing is that A, it doesn't have high accuracy, and B, it's not always done at the right time of the cycle. And, we all know that women's hormones go up and down throughout the cycle. So you need to have a specific timing to measure these hormones and complement the picture with, clinical opinion, ultrasound, and so on, to really help a woman understand her body with confidence rather than just create anxiety.
Absolutely.
So I think it's some progress, but we need a bit more refinement about how they're used, these home testing.
Yeah, thank you. So let's just go back to the name, because there are so many problems with the name, I think. And I know that there's been quite a lot of debate in the community, the scientific community, about renaming PCOS. But maybe just going through some of those issues with the name might help people to understand exactly what PCOS and what it isn't. So first of all, polycystic ovaries, not, as you described in the Rotterdam criteria, not all women need to have those polycystic ovaries to be diagnosed. Number 2, as you described, they're not actually cysts in the way that we think of a traditional cyst, a fluid-filled sac. It's not that. So maybe we can talk about that in a little bit more detail. And it does make it seem, with that name, that it's all about the ovary, when actually we know that this is a disease which affects the whole body. So can we just talk about some of those things, though? So number 1, you don't necessarily need to have polycystic ovaries on a scan to be diagnosed.
Correct.
Yeah?
Yeah.
Can we talk about the follicles versus cysts? So exactly what is a follicle?
Fantastic. So when a lady is born, she's born with a certain number of eggs, and they are somewhat dormant in the ovaries until she starts, having periods, menarche. And then every cycle, a lady will be recruiting 4 or 5 of these follicles that have been, dormant eggs to basically grow. Eventually, one will ovulate and become a fertile egg to meet a sperm and for a lady to get pregnant. That's, our, reproductive purpose in life.
Yes.
And in PCOS, what happens is that the synchronicity of these hormones secreted from the brain to the ovary is lost. Right. So the hormones are secreted, or sometimes not secreted at all, in a very irregular fashion. And that causes these follicles to progress. And then typically, so a follicle size needs to be about 20 millimeters before it ovulates. So these follicles progress to about 9 millimeters and then they stop. So that's what we call follicular arrest.
Right.
And that's why we see the ovary filled up with these follicles, because they progressed a little bit and then they got stuck. And then there's another wave that gets stuck, and so on and so forth. And that creates that appearance of, small little cyst on the ovary.
Yes.
So it's a manifestation of the irregularity of the hormones rather than something wrong in the ovary itself. And that's why I would say the endocrinologist will tell you it starts in the brain.
Yes.
However, there are negative feedback mechanisms between the ovary and the brain. And so therefore, you can say that, the ovary ovaries irregularity also plays a role in feeding into that hypothalamic irregularity, and therefore creates the typical vicious cycle of PCOS, where someone is having irregular hormones, they gain weight, their weight increases their insulin resistance, that suppresses their hormone, like ovarian hormone, and that in its turn also feeds into more irregularity.
Right.
And that's why, we see a lot of women, they're struggling because they keep gaining weight. They come and tell me, well, look, I'm not eating anything different than my friend who's like very thin and eats the same amount. I'm even less, but I'm still gaining weight. It's because of this whole metabolic irregularity that's happening, endocrine irregularity, and therefore they get stuck in that vicious cycle.
Okay. So let's talk about that then. So you've mentioned the metabolic changes, and I remember learning about PCOS and that it was kind of the central theme of PCOS was about the metabolic changes. So can you describe, I think we hear a lot about insulin resistance in the media, but not necessarily everyone understands what it really means. So can you talk about that?
Sure. So we all know that your fatty tissue is actually an active endocrine organ. So that plays a role in secreting hormones, and that also plays a role in increasing insulin resistance, which is the basic principle behind type 2 diabetes that comes with weight.
Yeah.
And similar process in PCOS, because of these hormonal irregularities, that insulin resistance is gradually creeping in the background, and then there is more and more increase in fatty stores.
Right.
And we actually published a study where we have shown that women with PCOS have something called metabolic inflexibility, meaning a woman with PCOS body is less able to process sugar compared to someone who does not have PCOS.
Right.
So they're more likely to take that sugar and convert it into fat rather than burn it quickly.
Right.
And that all feeds into this vicious cycle that I was mentioning that. And this is why it's so easy for them to gain weight and it's so hard to lose weight. And that, I think, is the purpose of a lot of stigma where, the patient will go to see a doctor and then the doctor will say, just lose weight and you'll be fine. But it's actually really hard for them that their pathophysiology is working against them. So whatever treatment needs to be really tailored to the nature of PCOS rather than just a standard lifestyle intervention to aid weight loss in the general population in essence.
Yes. Okay. And can we talk about how that then relates to the fact that PCOS is a whole body disease, it's a chronic disease with actually risks that go beyond just reproductive health. So let's talk about that.
Correct. So that is a very important angle because in the UK and pretty much everywhere in the world, unfortunately, the care for women with PCOS is fragmented across too many specialists.
Yeah.
So typically, a woman with PCOS needs to see a GP, a gynecologist, a fertility specialist, an endocrinologist, a dermatologist, a skin doctor, and every now and then maybe a psychologist for mental health issues. And so you can see the care is spread across 6 different doctors, not mentioning other disciplines, dietitians and what have you. And that invariably leads to fragmentation in the care is provided. And historically, it led to fragmentation in the research being done because each group will do the research on their symptoms rather than on the whole condition or disease.
Yes.
And that's why we've been advocating for specialist PCOS clinics in the NHS, where a lady will come, she will see a specialist gynecologist like me and an endocrinologist and has straightforward referrals to skin, to bariatric surgery, to dietitians. So there is centralization of their care around all of their symptoms. And like you alluded, it's a syndrome that affects all of your body. So it affects your reproductive health, it affects your menstrual health, it affects your metabolic and endocrine health, affects your skin, and affects your mood and your mental health. And so it's important to cover all of these at every consultation, at every point of contact with the doctor. We need to review all of these symptoms together to create a holistic treatment plan rather than someone coming to see a fertility specialist say, here you go, have these tablets to ovulate and then come back later when you have gained more weight and your pregnancy is more complicated and you had type 2 diabetes. And to your point about long-term issues, is we know about overweight, obesity is about 50% of women with PCOS. There's a high degree of conversion to type 2 diabetes later on in life. there's a higher risk of having endometrial hyperplasia, which is thickening in the lining of the womb that is a precursor to cancer. And that's because women with PCOS don't ovulate, and therefore the lining is thickened, and then it can become cancerous basically with time. There's higher prevalence of sleep apnea, where there's snoring and low oxygen at sleeping time, and that can increase the risk of stroke and cardiovascular disease later on.
And is that independent of weight?
Correct, independent of weight. Yeah, it's higher in obviously overweight or obesity.
Yeah,
but it has been shown to be independent with PCOS.
Right.
And then, as I mentioned, there is very, very prevalent and often not addressed depression, anxiety, body image issues, and
disordered eating.
Correct, and psychosexual as well. There's dysfunction. There's a lot of that among couples that we see with PCOS coming to have fertility treatment, basically.
Yeah.
So really, the key, if I am to say something today, is we need to do a better job to look at women with PCOS holistically, understand all their symptoms, and help them to get better across all the different systems that are affected by this syndrome.
I completely agree. And part of that is spreading awareness that if you've been diagnosed with PCOS, it's not all in your head. If you feel your mood has been affected, if you feel that you can't lose weight, if you feel that you've got disordered eating, all of these things, absolutely it is related to your PCOS, and you absolutely deserve to get the care for all of those things, not just someone talking about necessarily periods or fertility. It is about the whole picture, isn't it?
Indeed.
Let's just go back to diagnosis, because I did want to talk about teenagers in a little bit more detail. So we know that in teenagers, even when you get your first period, that brain-ovary connection is still immature. And because of that, you don't ovulate every month. It's not regular, and that can go on for a couple of years. And we also know that in teenagers, it's more common to get polycystic ovaries on the scan. So let's talk about how the diagnosis differs between teenagers and adult women, because I think that's probably an area for confusion. That, if I'm a mother of a teen girl and I've got a daughter who 18 months out is still having very irregular periods, does that mean she's got PCOS, or what does that actually mean? So,
very difficult area to navigate. And the reason is because, like you rightly highlighted, the symptoms can be completely part of normal puberty. And I think the consensus in the community right now, based on available research, and it's actually a hard population to research. Like, you can't really do a lot of research on teenagers or non-adults as easy as adults. So that creates a lot of barriers, unfortunately. But the consensus in the community is to work collaboratively with the teenage patient to help them understand the body, try to address their symptoms, and don't rule in or rule out PCOS. As in, you say, okay, you're slightly overweight, your periods are irregular, we can see some cysts on your scan, you're having a little bit of hirsutism. Let's try to address all of these separately. Unfortunately, the answer is commonly the pill, which I don't think it's always the standard treatment. It works in some patients, but it doesn't work in many, particularly for teenagers.
Yes.
But then when it's been more than 7 or 8 years since puberty, and the symptoms are persisting, that's when we can confidently make a diagnosis of, okay, you have PCOS. Because
that's quite a long time.
Correct.
Because actually, in my thinking, it's always been, well, if your periods don't regulate within 2 to 3 years, then we can think about it. But actually, you're saying that we can give them a lot more leeway.
Well, it depends on how their periods are manifesting, the level of the irregularity, when did they actually start their menarche at a normal age or so on. So I'm simplifying it. Obviously,
no. There
are more and more caveats into it, but that's how long it takes for the axis between the brain and the ovary to fully mature. But what I'm trying to say is, don't tell them, no, you're not PCOS, and go home and just work on yourself. I think it's always about saying you are at risk of PCOS. We need to work with you. We need to have concurrent care between, say, myself, the gynecologist, and their GP, and then keep seeing you maybe once a year just to assess how things are, suggest some treatments. Could be Metformin, for example. It could be weight loss interventions. Could be many other things. And then if, despite all that, the symptoms are manifesting and continuing, then that's when we make the diagnosis of PCOS. And that's an important point, is that PCOS is a lifelong disease.
Yes.
So it's not going to disappear. And there is no treatment of cure for it. There are very effective treatment that helps us control pretty much all of the symptoms. But there isn't a tablet that I can give that will make this PCOS disappear.
Right.
And so I think that's sort of the engagement and education that needs to happen around teenage ladies.
Great. Okay. Let's move on then to management. You've touched on it before that it can be incredibly frustrating for women when they present to a GP, they've had a diagnosis and they feel that the first thing that they're going to say is you need to lose weight. And not only is that sometimes not accurate because they may have lean PCOS, they may not have overweight or obesity, but as you said, it can be incredibly difficult to do that. And it can seem very dismissive. On the other hand, though, we know that weight loss in women with overweight and obesity can help in PCOS. Correct. Is that right?
Correct.
So can we talk about lifestyle management in PCOS and what that should look like?
So as I mentioned, is that we have to appreciate the pathophysiology of PCOS and why a lady who is otherwise active, exercising, eating somewhat healthily, is still gaining weight. And that has to do with the endocrine metabolic abnormality that are at the background.
Yeah.
So the intervention needs to be very tailored to really address that. So for example, if I just tell them, go and follow a standard hypocaloric diet, it's very unlikely they will gain or like they will lose a lot significant weight.
Right.
However, what we're seeing more success with is diets that are particularly focused on reducing glycemic intake or like anything with sugar, because insulin and sugar is the key sort of trigger in this whole equation.
Yeah.
So things like intermittent fasting or keto diet, they're showing some promising results in available data.
Right.
There is more and more data. We were actually hoping to start a study looking into intensive weight loss, like fluid shakes based interventions. They are really tough because for 3 months you are on only, liquid shakes.
Yes.
But there is very, very substantial benefits and restoration of ovulation, restoration of normal cyclicity and reduction in hirsutism and so on. So these are in terms of lifestyle intervention. But the other flip argument is now we have a lot of other alternatives that are available. So GLP-1 agonist, I can't tell you it's a revolution that is happening, with some caveat. I don't like it being, prescribed like Tic Tacs.
Yes.
We have to, we try to do it within a proper dietary approach and stepped approach and so on. And also bariatric surgery. So for some women with PCOS with a BMI, say above 40, with some, like they are pre-diabetic, sometimes we say, look, bariatric surgery is the best thing for you. And there has been a recent trial called Bambini, published in The Lancet, where they showed that after bariatric surgery, these women did very well. They got pregnant spontaneously. They restored their ovulation. Their pregnancy outcomes were actually quite good. So it's quite promising. And bariatric surgery is becoming more and more safe. So I'm not saying everyone needs bariatric surgery, but
it's an option.
Correct. So there are several options. Sometimes it's something as light as, take metformin and follow intermittent fasting and you can reach your goal. In some other cases, it might not be the case. You need something a little bit more aggressive, like, for example, a GLP-1 with, a regimented sort of lifestyle treatment and dietary protocol. And we see a lot of success with this. But obviously, it takes a lot of strong will and concurrent work with the patient to reach these objectives.
Absolutely. I just want to go into a little bit more about weight loss versus diet specific. How much of the benefit of what you're seeing with these dietary changes is about weight loss? Or how much is it about if you don't lose any weight, but you change your diet to be of a lower glycemic index, you go onto the keto diet, you do some fasting, but you don't lose any weight, do you still get benefit?
Yeah. So that's the difference between what is a weight loss diet and a maintenance diet.
Yeah.
And so to your point, I say if someone is coming to me with PCOS and they're actually, say, BMI 30, they're sort of okay, but they're still getting some irregularity. They're still getting a lot of acne, for example. We do see, although the research is very limited, unfortunately, in terms of what available trials, But if you go on a low glycemic diet, say Mediterranean diet, or specifically low glycemic index diet, they see some improvement in the symptoms, particularly when it's complemented, say, with metformin, for example. And there is improvement in cyclicity, reduction in acne, and so on and so forth. So there is a maintenance diet that we need to recommend. And, sugar is the enemy. And there is a weight loss diet, to your point, that you don't need to be in a continuous weight loss mode, because that's not good for your body. As in, like, your body will get used to it and, will revolt and you stop losing weight. So it's about the alternation between these two modes that I think is the key to success.
So even for women with PCOS who have a lean phenotype, you would still be talking about diet?
Correct. Correct. Because even in that group, they typically have somewhat slightly higher insulin resistance. And there's high sugar intake. There's a lot more conversions to promote their androgens. And so, again, the research is a bit gray on this area, but reducing that sugar intake probably has a role in also addressing some of these symptoms.
Okay. And can we just talk specifically about what it can help with? So can it help with acne?
Correct.
It can help with acne. Can it help with hirsutism?
Cyclicity and a little bit with hirsutism.
I see.
The problem with hirsutism is the treatment cycle to hair is long. So, it needs more than 3 to 6 months before you're having the new phase of hair to see some benefit. And most available studies on lifestyle are maximum 3 months.
Right.
So that's why we don't really know, because they're very difficult to do for beyond 3 months in controlling and everything in expensive studies. So there is a little bit of a gap there in terms of what research is telling us. But there is more benefit that way, particularly, say, for example, if you're complementing the hirsutism treatment with an intermittent laser or epilation, and then, going into lifestyle. There are I can report some results from the, clinical practice, but as I said, the research, there is very little robust research in this area, I'm afraid.
Okay. But it does sound like it's quite a powerful tool then, lifestyle medicine. Correct. And actually it should be, but it is a tool that should be really offered to everyone.
Correct.
Okay, so let's go into those two agents that you mentioned that aren't the pill that can help some women. So metformin and GLP-1s. You said that the evidence base is kind of evolving for GLP-1s. Is that right?
Correct.
So what do we know about it at the moment?
So for metformin, it's been very well-established treatment. There is 30 plus randomized trials on its benefits in PCOS. We don't have an agree on what dose to take. It can cause some disturbance in the stomach, but you titrate the dose accordingly. Yeah. But it's a very safe drug. Weirdly enough, there's still a lot of barriers for GPs to prescribe it in the UK. I don't know why. It's a very safe drug.
Very safe drug.
And a lot of billionaires are using it for longevity. So,
it doesn't work, but yeah.
So, I'm pro GPs being empowered to prescribe it for women. I don't see a barrier for it. But unfortunately, I don't know if this is...
We prescribe it for diabetes all the time.
Correct.
Very strange.
But in the UK, we don't even have one single drug that is licensed for treatment of PCOS. So all the medication we use are off license for PCOS, which is sad reality.
Yeah.
But that's because this group of patients has often been excluded from trials and from research. So metformin is used off license in PCOS, but it's very safe. And I put my patient on it, long term, no major concerns at all.
When you do you just titrate them up to the highest dose that they can tolerate?
Correct. Yeah. Yes. And in regards to GLP-1, as I said, it's a revolution. And last couple of years, we heard about the oral Ozempic.
Yes.
And that I think is going to change also how people are using it and so on. While it is showing very good data in terms of weight loss, the downside is there is a significant muscle loss as well with it. So that's why we're a bit worried, particularly women with PCOS are, younger in reproductive age women. So there is some caveat about don't lose your muscle mass, because there is now more data about rapid aging with the prolonged use of GLP-1 and Ozempic phase that we all see in a lot of Hollywood stars. So that's why we recommend usually to use it as a catalyst for weight loss. So when someone is in that vicious cycle that I mentioned, GLP-1 plus other medication could be that catalyst to really help them get out of that, gain control, and then go into a maintenance stage like we discussed.
Absolutely.
And so that typically is 3 to 6 month use with proper dietary support, identifying what elements to take out of your diet plus the GLP-1, achieve that weight, stabilize, and go back to gradually normal diet. And we've seen a lot of success with that. Again, I'm reporting, anecdotally.
Yep.
There isn't enough studies on GLP-1 in PCOS. We were thinking about doing that, but it's super complex in terms of if you have someone coming to you with obesity, lack of ovulation when PCOS, and you give them GLP-1, are you helping them to achieve a healthier pregnancy?
Yes.
And the design to this study is so complex and so expensive. I don't think it will ever happen, unfortunately, but maybe one day.
Yeah.
And the other key thing is that these GLP-1s are teratogenic.
Right.
So I get asked a lot from a lot of journalists about, that they're aiding pregnancy, that a lot of women are getting pregnant on them, which is a manifestation of them getting back their ovulation that was missing.
Yes.
But someone should not get pregnant on these. They need to have a reliable contraception if they're using GLP-1 because it can affect the baby.
And how soon before trying to conceive should you stop it?
Depends on the type of them. So for Ozempic, to my knowledge, is 3 months. For Mounjaro is 1 month. So you need to allow a washout period. And that's what we try to do. So typically, if someone is coming, say their BMI 35, we work with them to reduce their weight with GLP-1, create a program. Then once they reach that target weight, we allow that washout period, and then immediately we help them to go into an ovulation induction cycle.
Right.
So they can get pregnant at that top healthy point.
Yes.
And that also helps them in their pregnancy because women with PCOS are at higher risk of gestational diabetes that can then convert to type 2 diabetes afterwards, as well as many other risks in pregnancy. Preterm birth, gestational growth abnormality for the baby, miscarriage, and what have you.
Yes.
And weight plays a major role in reducing all these risks. And so that's why we try to optimize the timing to start fertility treatment so that, they're entering pregnancy at that top health point.
Amazing. And so as you were saying, and as you were describing in your own clinical practice, using GLP-1s as a tool, but it's part of an entire program.
Correct.
Yes, you might, with any, extreme weight loss, you may lose muscle mass, but it's about making sure that you're weight training and you're eating adequate protein and you've got that, nutritional support as well, and exercise support. So it's not just one thing that you're doing. It's part of a complete program.
Exactly.
With metformin, what can that help with? So I've always thought it was weight neutral. So in PCOS, I know that we can, I believe it's been shown that it can help induce ovulation. Is that correct?
It doesn't induce ovulation in itself. So it's not an ovulation induction agent. It can optimize the response to an ovulation induction agent.
Got it.
Like clomiphene or letrozole. There are quite a good number of trials to show that in high dose metformin, so I'm talking high dose 3 grams a day, which is often upsetting. Yeah. Someone can lose up to 5 to 10% of their weight over a 6-month period. Yeah. So it does work on optimizing that insulin resistance threshold, therefore addressing that, a metabolic inflexibility element that we were discussing, and aid weight loss plus a lifestyle intervention. Right. On its own, is probably the effect is minimal, even at the higher dose. But that is the mechanism of action, is purely around the insulin sensitization element. And because insulin has a negative feedback, into the hypothalamus and the production of, the hormones to induce ovulation. So once that is down, a lot of women will restore their natural ovulation and therefore get pregnant. And that's why a lot of these women on GLP-1 who are losing weight suddenly are ovulating again. Yeah. And that's how they get pregnant.
Do you think with the advent of GLP-1s that metformin is now going to be obsolete, or do you still think there's a place for it?
I still think there is a place for it. Typically in my practice, when someone has finished their GLP-1 and they want to maintain, I put them on the metformin. Got it. Because it's safer and much more long-term. And again, I'm a bit wary of the addiction to GLP-1. We're seeing people being on it for 2 years now, which is, has a lot of health concerns that comes with it. So, again, I think the wise approach for now is to use it as a tool, as a catalyst to gain control of your health rather than something that you get addicted to for the long term.
Yes. And you must have a lot of women who do have that lean type of PCOS, but do have the hirsutism and acne, who must be coming to you saying, well, I've heard that PCOS responds really well to GLP-1. I want to be on a GLP-1. And even though I am lean, I have got issues with disordered eating. So I think it would be really helpful to me. What do you say to those women?
I'd say it's probably not the wisest approach. I tell them you're lucky you don't have the weight element.
Yeah.
But it doesn't mean that you just take whatever treatment that worked for someone else. Rather, we will work with you to really unpick what are the issues, what are the symptoms, and try to address them. So, for example, we just published a study to show that Metformin plus a treatment called spironolactone actually is very effective to reduce hirsutism.
Yes. So spironolactone acts as an anti-androgen, doesn't it?
Yeah.
Yes. Okay.
So sometimes, always tailoring the treatment to the particular individual symptoms is key to help them, achieve the outcome that they want. So just giving them a GLP-1 will not address the problem for them. We just need to really work on their exact pathophysiology.
Yeah, so personalised medicine is essentially what you're talking about. Let's talk about supplements, because I think every doctor gets asked about supplements a lot, and I think this is quite big in the PCOS space as well. What supplements have evidence? Because Inositol gets talked about a lot. What do you think about that? Inositol
does fill some gap. There are, I think, about 8 trials to date. Bear in mind, majority of them are funded and published by the manufacturer of Inositol. So there might be some degree of bias there. It has some good results for metabolic enhancement.
Okay.
As in, it seems to help to regulate some of the insulin outcomes and some of the weight elements. There isn't sufficient data about its role in fertility optimization. So typically, we see a lot of women with PCOS who are starting fertility. Their fertility doctor will start them on Inositol. And the real answer is we don't know the effect. Maybe it works, maybe it doesn't work. And we know it doesn't harm. So that's, I think, my approach to it is that, look, it doesn't harm you. There might be some benefit. If you feel like you really want to go on it, plus say metformin, then I'm happy to support that. But currently, we don't have robust data that it helps in all the symptoms of PCOS. It might add some value to weight stabilization, metabolic performance, and so on.
Right. Okay. Any others that are on your radar?
So vitamin D, very important. There is quite robust data by now that by default, women with PCOS have lower levels of vitamin D, and it has to do with the absorbency and so on.
Right.
Obviously, if they're trying for pregnancy, folic acid is very important. We see there are a few data out there about the role of magnesium supplementation, calcium supplementation, and some data for some reason comes a lot from Iran in terms of studies about chromium and about cinnamon. So again, I can't really vouch for it, but these are some of the things that are often spoken about in terms of you see them in the literature. Do they help? Maybe there is some additive benefit, but it's minimal. But, as I'm saying, as long as it doesn't harm, then it's probably okay. And the main barrier here is often cost, because when you take 4-6 supplements, it's suddenly quite expensive for the patient every month. So just about, sharing this information, and then every patient will choose what they're comfortable with, really.
Absolutely. And just having an awareness that often they are unregulated, and it's just being aware that what it says that's on the label might not be what's in there. So it's having that awareness, particularly if you are thinking about fertility and going on that journey as well.
There are a lot of additive agents and so on.
Absolutely. Okay, let's go on to, I think, probably the most controversial aspect of this discussion then, the pill. Because I think we've seen an enormous amount of backlash from the pill from women in the last few years. And I don't think it's all unwarranted. And I do want to make sure that we kind of acknowledge women's feelings about the pill, which in some times are quite negative. I think, in some ways, we brought it on ourselves, because I don't think in the past we've been very good at explaining exactly what the pill is, what it does, how it works.
Yeah.
And I think also there's this just level of frustration in women's health that, it's not necessarily about the pill in itself. It's more about the idea that when we talk about a lot of women's health conditions, there is just such a lack of medical management options. And I think that's what we're seeing as part of the backlash is this frustration like, well, what else is there? And I know, as a patient myself, I certainly feel that. And as a doctor, with cholesterol, I've got so many things. I've got statins and fibrates and ezetimibe and PCSK9 inhibitors and so many options. And I think for women, they're saying, well, where are our options? And I think that's part of the problem. So I think it's really, really important to acknowledge that and also acknowledge the fact that it doesn't work for lots of women and lots of women do feel awful on it and they're intolerant to the synthetic hormones. With that said, there is a role for the pill in the treatment of PCOS. Is that right?
Look, I cannot agree more. And I think this whole thing manifested from the fact that we doctors have been simplifying PCOS into let's regulate your periods.
Yes.
And so often a lady would come to the GP, as I mentioned, on these 2 touch points and say, well, my periods are absent for the last 3 months and I'm getting some hirsutism. So the traditional approach, which is dismissive of the whole nature of PCOS, is, look, I'm going to give you this pill that has some anti-androgen features into it, and I'm going to regulate your periods and reduce your hirsutism. Okay, that helps with 2 symptoms, but it doesn't help with the whole syndrome. And that's what I think is missing. I think my GP colleagues are amazing in that they can do a consultation in 10 minutes. I cannot. It takes me at least half an hour speaking with the patient with PCOS to understand everything that they're going through. So there are challenges in terms of the type of care you can access, but it is what it is. So I think it's important not to sell the pill as the first line of intervention, because it's not. It does help to address some of the symptoms of PCOS. So
let's talk about that. Yeah.
So when it comes to why someone is not menstruating, typically women with PCOS can go for years without any periods, which is very unhealthy. And as I said, it can provoke endometrial hyperplasia. So we recommend at least 4 periods a year.
Yes.
Like every 3 months have 1 bleed minimally.
Yeah.
So the pill will address that problem. When you have a pill, you have regular bleeding, problem solved.
Yes.
The problem is that it sort of addresses one symptom and then you forgot about everything else.
Yeah.
So when it comes to that works. But then, hey, some women come and tell me, I don't want to have it every month. So I say, have a progesterone pill, just induce an actual bleed every 3 months and try to work on all the other angles.
Yes.
So that hopefully we can restore your natural cyclicity. Some women say, look, I just want a reliable contraception. I hate taking pills every day. I say, fine, have a Mirena, have a coil inside the womb that can minimize that. And maybe you don't want to have a period every day. It's all about individualizing the treatment and patient preference. Now, the other element where the pill can help is some types of the pill. So say like Yasmin, Diane, and so on. Some newer pills are coming like Drovelis. They have these anti-androgen element in their progesterone, and therefore it can help to reduce the hirsutism and the acne as well. So that's why it's been typically the sort of holy grail treatment for PCOS.
Yes.
But hey, we have options for anti-androgens separately, like I mentioned, spironolactone, flutamide, duostride. There are many other options that we can use if someone does not want to have the pill.
Yes.
So it's not like you have to have the pill or you have no other options. There's so many different options, but just about explaining to the patient the objective of each treatment.
Exactly.
And the pill can work very well to many patients. Bear in mind, if someone has a BMI above 30, it's a contraindication. They can't have the combined pill. So we have to resort to other options that address all their different symptoms.
Yes.
Typically, as I said, I see it a lot being prescribed in the early years of PCOS. So someone 20-something or, presenting with these symptoms, they have the pill, come back when you're ready to have a family. Again, I think it's a bit dismissive and brief. Women with PCOS have so many other elements to manage their health.
Absolutely.
But it does have its case use. Definitely, we're not letting go of the pill, but probably the message or the approach is to refine its use and, go a bit more individualized about what really you want to do, what sort of pill, because there are 30 odd pills. They're like different.
The pill is not the pill.
Yeah,
there are lots of
exactly.
pills. Yeah. Okay. So personalised care again. Then you mentioned before when we were talking about teenagers that often that's been the default, is that, okay, well, your period's irregular, you've got a bit of hirsutism, you might have PCOS, here's the pill. And you said in particular with teenagers, that's not something you like doing. Talk to us about that.
So the downside is that it can mask symptoms sometimes. It can contribute to delaying their diagnosis, because you give them the pill, they come back 10 years afterwards, say, I've been on 10 years on the pill, I don't know what's happening in my body.
Yes.
It might be working very well for them. I'm just highlighting the elements into it.
Yes.
And sometimes in some teenage, it can itself promote weight gain.
Right.
So we just have to be a bit careful. As I said, not all pills are equal. There are 30 plus types in the UK at least. They differ between countries as well. I know we have an international audience, so I don't want to keep it very UK centric, but so many different types of pill. They have different side effects. Some work okay in teenagers, some don't. It might have different impacts in different ethnicity and population and so on. So again, just really understanding what sort of pill you're prescribing to which patient.
Right. Okay. And there's been lots actually on social media recently about the impact of the pill, particularly in teenagers. You talked about it on weight, but also there's been talk of it on depression.
Correct.
And the fact that it's different between teenagers and adults. What do you make of all of that?
We actually just published a review highlighting the impact of low mood that comes with being on contraceptives for a very long time. Particularly, we think it's relevant to synthetic progesterones that are inside the pill. And there is now this drive towards using more body-identical progestrogens, particularly, say, in the menopause, because they seem to have less impact on mood, depression, and anxiety. So being on a synthetic progesterone for a very long time seems to have quite a prominent side effect, in terms of mental health. But like we discussed at the start, often, unfortunately, mental health in women with PCOS is dismissed.
Yes.
Or it becomes like sort of, you're there, deal with it. Or we don't have the right tools, I think, to describe it, assess it. And also, we can't summon help. So in my clinic, even if I am to screen for depression and anxiety in the NHS, in our PCOS sort of population, there isn't, unfortunately, a way forward for me to refer and summon help.
Yes.
If I bounce it back to the GPs can't cope with it. So it's unfortunately a gap in the current health system, and we do need more awareness about the importance of mental health. And I often encourage patients to reach out to charities, patient support groups. Like in the UK, we have the Verity PCOS charity. They're very, very helpful. They often can, offer a body or a community to discuss all these elements. And that could be very helpful in itself as well. So yeah, being on the pill long term can have significant adverse mental health outcomes. And, I think all doctors should be aware of that and screen for that with prolonged use of it.
Really interesting. Okay. So I wanted to do a little section where we look at some videos that are on social media, and we just kind of discuss the issues that are raised in them, because I think one of the reasons why I'm doing this podcast is because I think a lot of women, a lot of people now get their medical information from social media. And I think if they're there, then we need to be there.
100%.
And if they're there and they're looking at these things, which do tend to get amplified, then we need to be addressing them, because when they come in, that's the information that they've got in their heads. So, and we need to know what that is. Yep. So let's look at the first one.
When you get off birth control, what is the best way to train your body how to cycle naturally again?
I wouldn't just ditch birth control willy-nilly without a plan. And there's something called post-birth control syndrome. And it is when if you got on birth control because you had irregular cycles, painful periods, well, that stuff is waiting. Because all you did was put a Band-Aid and basically put a muzzle on it for however many years you were on birth control. To avoid having this crazy whiplash of symptoms come back at you, I really recommend following some kind of hormone balancing protocol first.
So what about that then? So in that, she said a couple of things. So one, is that you can't just stop the pill, that you need to wean off somehow. You need a hormone balancing protocol, by which I think she means lifestyle and supplements. And the second thing that she's talked about was that the pill is a Band-Aid, it masks, and when you come off it, you'll have something called post-pill syndrome. So let's talk about those things.
Colloquially, yes, as in like a lot of women who've been on the pill for very long. What the pill is doing is basically giving very high levels of the same hormones that the ovary is secreting, and therefore it puts the hypothalamus and the ovary on complete hibernation. That's the job of the pill, and that's why someone does not get pregnant when they are on the pill. So if someone has been on it for a very long time, we do see that a lot when they come off it, whether they have PCOS or not, then their hypothalamus might not come back in rhythm. And sometimes they go to become amenorrheic, not having periods for a very long time. It is relatively common, and the good news is relatively treatable, as in like with some lifestyle advice, with some support, with sometimes provoking some withdrawal bleeds with just progesterone, for example, that can come back into a normal, natural rhythm. In PCOS, it's slightly different because when you are off the pill, you came back perhaps sometimes to the state of irregularity that has been happening. It might have been hibernated by the pill, but then, when you're coming off it, as I said, why you're coming off it. So if someone is coming off it to get pregnant, then what I would say, go to see the fertility specialist, work with them to go into an ovulation induction treatment protocol where you get in other pills to help you to ovulate and get pregnant immediately. If you come in off it because you don't like the pill or you get a side effect of the pill, that's completely fine. But then what is the alternative? So are you going to have withdrawal bleeds on progesterone, for example? Are you supplementing it with a Mirena? Or you're giving your body a break and then, you're aware to watch for when you're not having the periods so that we can induce a bleed and continue to be on that healthy plan while, for example, taking other options like the metformin, like the supplements, like the lifestyle and what have you. So I agree in general that, you're going into the pill for a reason, you're coming off the pill for a reason. And as long as these are discussed and there is a plan before and after, then you should be okay. But just about speaking with your health professional about it.
Okay, so post-pill syndrome is actually a thing. It can happen in women who don't even have PCOS, and it's just about the reawakening of that brain-ovary connection that can cause some symptoms. Or it's about, and this is to her point about it being a Band-Aid, the pill, which I do take a little bit of issue with, is that it's just the underlying mechanisms of PCOS actually showing themselves again. The reason why I take issue with it is because when people talk about a Band-Aid, it's almost in a disparaging way. We've talked about the pill and I think we've had quite a balanced discussion about it, but it is a treatment.
Correct.
And like many other treatments,
Correct.
If I give a treatment for high blood pressure and it treats someone's blood pressure, well, when they come off it, if they haven't done anything else with their lifestyle, their blood pressure is going to go up again.
Correct.
Same with cholesterol, same with anything. So I think of that as a treatment, even though it's not a cure. I would say that if you've had those problems, and as long as you've got into it with the right knowledge, if you've been counselled correctly and know that it's not a cure and this is why we're going on it, and you've had your proper diagnosis and actually it's right for you at that time, then the pill is a treatment.
Correct. Look, you can make this argument for any non-curative treatment.
Yes.
Someone has diabetes, they're on insulin. As long as they're on insulin, they're fine. You take the insulin out, obviously they're going to get worse. And it's the same thing with PCOS. There is hormonal irregularity. You can manage it with the pill, one of many other treatments. When they are off the pill, their hormonal irregularity is going to come back to show.
Yeah.
It might come in different formats, in different severity, in different frequency. But, as we discussed, there is no curative treatment for PCOS. It will always manifest somehow until menopause, and sometimes even beyond menopause, there's still some symptoms. But you always need a treatment plan on how you're addressing your symptoms, depending on which symptoms are appearing. And the other important thing is that PCOS changes throughout the life cycle of a woman. So from the teenage years, from the, just post-menarche to the reproductive age years to the perimenopause stage, the symptoms will vary And it's not like if you've been on one treatment, it will work for you for 30 years. It
Yes.
doesn't work that way. So there is always need to be alteration of what treatments you're following, depending on how your condition is manifesting and changing.
One of the common misconceptions is actually when a woman goes through menopause that the PCOS will go. Is that not the case?
Some of the symptoms of PCOS will disappear. Some others relevant to the metabolic inflexibility that we mentioned, sometimes the endometrial, tendency to have cancer, for example, endometrial cancer, the sleep apnea, the cardiovascular health elements, they might persist. They might change because of the element of the menopause. So there seem to be some prolonged impact, but they again, it's in a slightly different format because then that hormonal irregularity is disappeared, but there might be some other elements into it that are persisting.
Very interesting. Okay, let's just do one more video.
Fun fact, birth control can actually cause PCOS. So there's this whole group called post-pill PCOS, and it's people who have developed PCOS symptoms after having taken birth control, and they didn't have any PCOS symptoms before going on the birth control. Which makes you think, why prescribe birth control for PCOS then if it can cause PCOS? And that's simply because doctors only want to mask your symptoms. They're only worried about something they can do right in this moment so that you're not complaining to them.
Right. So the pill can cause PCOS. What do you make of that?
No, it's factually incorrect.
Okay.
So as we discussed, the pill is a treatment. It could be that someone had a tendency to develop PCOS when she was a teenager and she was started on the pill for a long time, then came off the pill, and then suddenly the diagnosis of PCOS is now formalized.
Yeah.
That happens quite a lot. But PCOS has an epigenetic element into it, and it is there whether there was a pill or there was no pill, it is there. And as I discussed, the diagnosis is a collection of symptoms. So we have to rule out other causes that could be also PCOS, like hypothalamic abnormality, adrenal abnormality, or what have you, before we make that diagnosis. So if someone has been on the pill since their teenage years for, say, 10 years, and then they stopped it and came off it, and then been labeled PCOS, it doesn't mean the pill caused it.
Yes.
It was just masking the symptoms, as we discussed. This is the job of the pill. It is masking some of the symptoms, and it actually makes it not possible to diagnose it based on the lack of periods, because you have regular periods. And the pill also reduces the polycystic appearance on the ovaries because there aren't any follicles coming forward. All the follicles are suppressed.
Yes.
So it takes away two of the symptoms that you can't diagnose PCOS when you are on the pill.
Yes.
And the bloods are actually skewed when you are on the pill. So you can't make the diagnosis when you are on the pill. So that's why when someone off the pill, you can make the diagnosis.
And how long do you have to be off the pill for before you try and make that diagnosis?
At least one cycle.
Okay. Amazing, Dr. Watter. That has been such a great and comprehensive conversation. I think that will be really, really helpful for women out there. Tell us, I know that you are big into your research. I know that you've got a lot of projects on. Tell us about one that's going on or what's in the future for you.
The most exciting projects that we are just finishing is we are working with the NIHR, the National Health Institute, and the Waterloo Charity in the UK to produce a health research priorities for women with PCOS, which is quite a really, really exciting element because for the first time we have lay women with PCOS having their voice into this and telling us, researchers, what we should be focusing on. Because often we ask the question that we think is important to us. Doesn't always mean that this is what the patient wants. So this is due to come out very, very soon. I'm really excited about it, and I think it will have a role in changing the priorities and funding available to research PCOS. So watch that space.
Amazing. Listening to women.
Yes, exactly. And the other exciting thing is, with the Verity, I think this whole thing is led by Verity Charity, is there is now an all-parliamentary group supporting and highlighting PCOS health issues. And it's been, discussed and debated in Parliament. And I think this is a very, very positive thing where researchers like me, clinicians and lay women are coming together to advocate and lobby for better support, better, healthcare provision and better research into PCOS so that we can hopefully find more, effective treatments. So these are the two things that I'm really excited about today. We have other research that is hopefully going to happen soon, as I mentioned, about fertility, how to improve the outcomes of ovulation induction and IVF and so on, we're working on. But these are the top 2 highlights.
Absolutely. And I deliberately haven't gone into fertility and PCOS because I do want to talk about all of the other things, because I think we talk about fertility in the context of PCOS so much that I really did want to give time for all the rest of it. The last question, if you had the opportunity to rename PCOS, what would you call it?
So actually there is an ongoing initiative and as part of the International Guideline Committee for PCOS to actually rename it. I can't tell you the final name yet.
Yep.
It's still been debated. The acronyms are still going to be the same. So it's going to still be PCOS, but it will not mean polycystic ovary syndrome. It will mean polymetabolic something endocrine syndrome, something like that.
Okay.
And the main driver for this is, unfortunately, because of the name ovarian, the research and funding available for this condition has been somewhat curtailed and isolated. So we hope that by changing the name, it will attract more awareness, and there will be more resources, focused to support this condition and more research in it. And also that's what a lot of the patients were advocating for, that it's not just about my ovary, it's about my whole health. So watch the space. Hopefully there will be a new name very soon.
Absolutely. I think so many of women's health conditions, endometriosis, PCOS, we're desperate for people to think about it more than just a reproductive health condition. We are women, we are more than just our reproductive organs. And it's great that the
100%.
scientific community are finally kind of waking up to that. That's great.
And, I'm sure your podcast is playing a major role in this awareness. So
well,
thank you very
I
much.
hope so. That's what it's about. It's about educating it and just getting those messages out there, which otherwise it takes so long, doesn't it?
100%.
Thank you so much.
Pleasure.
It's been an absolutely brilliant conversation. And that's it from us at the Women's Handbook Podcast.
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.